Welcome to our channel viewers. This is second video tutorial on inflammatory bowel disease. In this video tutorial, we have talked about Crohn's disease. In the previous video, we have discussed in detail about the ulcerative colitis. Crohn's disease is a puzzling subject and I find medical students and surgical trainees struggling with this topic to understand. We have covered in detail everything a beginner, a trainee needs to know about the Crohn disease, and we have combined theoretical discussion with a case-based discussion. I hope you will enjoy the talk. Stay tuned. So this is a real life case scenario which I am giving to you. So the diagnosis can be anything. It is not that it is Crohn disease only that we are discussing. So keep your option wide and let's start. So this is a 38-year-old male who has presented to us with history of abdominal pain for last 5 months, history of diarrhea for last 4 months, and intermittent history of non-passage of stool and flatus for last 4 months. So the main presentation is pain in abdomen, diarrhea and intermittent obstipation for last 4 to 5 months. The pain was acute in onset. It's located in the central abdomen, colicky in nature and used to get aggravated by food. There was no history of any radiation or referral to any other site. He had a history of diarrhea which was 5 to 7 episodes per day. It was semi-solid in consistency. There was history of loss of weight, which was undocumented loss of weight, and he also gave history of obstipation for last 2 days before presenting to the hospital, along with abdominal distension. He also gave a history of nocturnal symptom that he used to have the aggravation of symptom during night. There is no history of fever, any GI bleed, lump abdomen. There was a history of appendectomy at the age of 13 years. On abdominal examination, the bowel sounds were increased and there was mild distension present at the time of presentation. There were no visible peristalsis, lump or tenderness. His rectal examination was normal and his general physical examination was also unremarkable. We managed this patient on the line of acute intestinal obstruction with the help of IV fluids and other conservative measures. Rice tube was inserted and patient started showing improvement after 48 hours and he started passing stool and flatus after 48 hours of conservative management. Friends, make your plan. What is the diagnosis? What could be the differential diagnosis in this patient? And what are the further investigations required to work up this case and manage this case in a 38-year-old male patient with history of recurrent intestinal obstruction of almost 5 to 6 months duration. So coming to the topic of this video tutorial, the ulcerative colitis and Crohn disease, there are two phenotype patterns of inflammatory bowel disease. In Crohn disease, the inflammation is transmural. That means it involves the whole bowel wall and it occurs in any part of GIT from mouth to anus, and it is associated with development of complications such as fistula or stricture. While the ulcerative colitis, which we have talked in detail in the previous video tutorial, the link for which I will share in the description, it is superficial inflammation that occurs only on the colon. So that we have to understand from the very beginning that Crohn disease affects whole GIT from mouth to anus, and it is a transmural. That means it involves the whole bowel wall. from the mucosa up to serosa. While the ulcerative colitis, it affects only and only colon and maybe some part of the terminal ileum that we call backwash ileitis, and it affects only superficial part of the mucosa and submucosa, and there is no transmural inflammation. So with this basic understanding, we'll start discussing the Crohn disease in this video. The Crohn disease is a lifelong disease, and it arises because the interaction between genetic and environmental factor, so that the person who is genetically predisposed comes to the susceptible environment, he will get the Crohn disease. The Crohn disease is predominantly found in the developed country, but the landscape is quickly changing. That means more and more cases we are seeing in the developing countries, and more patients are coming to us in the clinical practice. The precise etiology is not known, so therefore a causal therapy is not yet available, so that we don't know the cause, so we don't have any specific curative treatment, and it is unlikely that the precise pathogenesis of Crohn disease will be understood soon, because we are not getting any breakthrough despite the extensive research about the etiology of Crohn disease. The most of the facts and figures which I have given in this talk are from these consensus guidelines, that is Third European Evidence-Based Consensus on Diagnosis and Management of Crohn Disease Part 1 and Part 2, and ECO-ESCP Consensus on Surgery for Crohn Disease from Journals of Crohn's and Colitis, published in 2017 and 18. We could add some new insight to your knowledge, and you will be able to manage Crohn disease patient more efficiently. Thanks for watching. Please like, subscribe and share. The channel subscription is free for life, and knowledge is invaluable. Thanks again. Happy learning.